Good morning, everyone. Thank you, Dr. Anju, for the introduction. In the next 10 minutes, I'll be dealing with the evaluation of ptosis. So, ptosis or blepharoptosis, as all of you know, it is the drooping of the eyelids. The 2 points I need to stress is that the head should be in the upright position and the gaze should be in the primary gaze. So, why do we need to evaluate a case of ptosis? It is only a sign, it is never a diagnosis. So, for ptosis evaluation, meticulous history taking is important. Examination and measurements are also required. So, in the history, first and the foremost is the age of onset, if it's a congenital one or an acquired one. The mode of onset, if it's an acute or a chronic. Acute needs more, it's more of an emergency. Always see if there is any history of trauma or any surgery, ocular allergy or recurrent swelling, because all these factors causes levator weakness. Now take a brief history if there is something corresponds to the myasthenia. So if there is any diurnal variability, history of diplopia, dysphagia, weakness of the proximal muscles, all this suggest ocular as well as systemic myasthenia involvement. Always take a family history if there is anyone with positive family history, because in some cases like BPU and CPO and BPS, it's inherited. And old photographs, always ask for the old photographs, because the patient may sometimes notice it very later, but often it's seen that many times it is present even before. In examination, see if there is any facial asymmetry for the frontalis overaction, or if there is any abnormal head posture, which is often a chin lift, especially in children. Now coming to the measurements of ptosis. First and the foremost is the palpebral fissure height. I need to stress two important points. That is, the patient should be looking straight and in the primary gaze. So palpebral fissure height, it is the measurement from the lower lid to the center point of the upper lid through the corneal reflex. And it is divided into two: marginal reflex distance 1 and MRD 2. So MRD 1, it's a distance from the center of the pupil to the upper lid, and it normally corresponds to around 4 to 5 millimeters. And I would like to say that the normal lid position, it's always 2 millimeters below the cornea. So here is ptosis of the left eye. Now coming to the severity. Mild ptosis is defined as difference of 2 millimeters between the two eyes. If it is 3 to 4, it's a case of moderate ptosis, and if it's more than 4, it's a severe ptosis. Now moving to the levator function test. So how do we do that? Always ask the patient to look down to the maximum and look up to the maximum. So the excursion of the levator, excursion of the how much the lid excurs, this is the levator function test. The measurement of the same is the levator function test. The very important points is that you always negate the frontalis. This is how we grade it. Less than 4 is poor, 5 to 11 fair, 12 to 14 is good, 15 to 18 is normal, and more than 18 is excellent. So importance of lid position on down gaze. This is the first picture. When the patient looks down, you can see that the right eyelid is at a higher position. So it's a case of congenital ptosis, because the muscle is unable to, due to its fibrosis, muscle is unable to relax properly, and it's a case of congenital ptosis. But in the second case, you can see that there is both ptosis, both eye ptosis is there, and left more than right. And when the patient looks down, left position, lid position is lower than that of the right eye. So it's an aponeurotic ptosis because of the stretch of the levator. Lid crease, you can see that in the first case, the baby has, the child, he has no lid crease in the left eye. So this is congenital ptosis. And in the second case, you can see that it has receded. This is a case of aponeurotic ptosis. Now Bell's phenomenon. how do we check the Bell's phenomenon? Ask the patient to forcefully close the lid and look for the excursion of the cornea. If it's less than 1/3 of the cornea, it's good. 1/3 to half the cornea, it's fair, and more than half of the cornea is visible, it's poor Bell's phenomenon. So why do we do this? This is to assess the risk of exposure keratopathy post-surgery. So you can counsel the patient accordingly. Now, the importance of extraocular movements is that this case, as an 80-year-old female, came with sudden onset of ptosis. On lifting up, there is the classic down and out position of the eye, restriction of adduction, elevation, and depression. It's a case of third nerve palsy. Other cases wherein ptosis and UM restriction are there. There is monocular deficiency, elevation deficiency, myasthenia gravis, then CPEO, or some cases of orbital masses, which causes multiple cranial nerve involvement. So this is a child. You can watch the position of the lid. Ptotic eye is opening up with the movement of the jaw. So this is a case of Marcus gun jaw winking phenomenon. It's a synkinetic ptosis due to the abnormal connection between the abdominal innervation of the lateral pterygoid. So in a case of Marcus gun jaw winking, always ask the parents what is their concern, if it is more the ptosis or if it's the jaw winking phenomenon. And you can counsel the patient accordingly. You can plan ahead based on that. Importance of pupil is that this is a case of mild ptosis with miotic pupil. It's Horner syndrome. And in third nerve palsy, in which the pupil is involved, it's a very surgical emergency, as all of us know. So myasthenia, how do we test for myasthenia? It's the most important test is the ISPAC test, which has got a very high specificity, around 90% of sensitivity. Here the ISPAC is kept over the eye for around 2 minutes, and you can see that after 2 minutes there is an improvement in the ptosis. It's a positive one. Now Cogan's twitch, how do we do that? Ask a patient to look down and then around 30 seconds and look straight and look for any upshoot of the upper lid. And fatigability, not that specific, but still ask a patient to look up for 30 seconds and look for the fatigueness of the upper lid. Now, Herring's-Low. So this was a CPO patient. She had her left eye surgery being done, frontal eye sling was done, and a bit undercorrected. And you can see that there is an increase in the ptosis in the right eye. She was counseled prior because she had ptosis, and so this is due to negotiation of the action of the frontalis in the other due to the Herring's-Low. So always counsel the patient accordingly. Always check the corneal sensation and dry eyes so that you can counsel the patient chances of exposure keratopathy. So not always all the drooping which appear as cases which appear as drooping of the eyelids, it's a ptosis. Some can be pseudotosis. Always be aware of the pseudotosis cases. So here the patient had come with small complaints of smallness of her right eye, but you can see that it is actually a case of lid retraction in the left eye. This is another case. Again, she had come with telling that it is a smaller eye in the right, but it's actually brotosis with dermatochalasis. This child, you can see that on cover test, what happened on covering the right test, the upper, left eye is taking its position. So always do a cover test and make sure that it's never a case of hypertropia. And this this person, he had come with a mild ptosis in the left eye. And on inversion of the upper lid, you can see that it's a salmon patch and it's a case of lymphoma. And this, it appears to be ptosis, but this is actually on her on fitting with the prosthetic eye. So it's a case of post-enucleation socket syndrome. So with this, I conclude this is why the ptosis evaluation is very important. Thank you.
Thank you, Dr. Indu, for that elaborate evaluation on cases. I call upon the next speaker, Dr. Ann J.K., who is the consultant oculoplastic surgeon at Little Flower Hospital, Angamadi. She'll be talking to us about ptosis surgeries and she'll be simplifying it for the listeners today.
Thank you, Dr. Indu, for having me here, and Dr. Anju. My topic is ptosis surgery simplified. So, ptosis surgery, there are various school of thoughts and various algorithms. So, I'll be talking what I will be practicing. First is decision making in ptosis, when to operate. So, if a patient is having visual obscuration or loss of peripheral view or concern of amblyopia and cosmetic concerns, we can operate. Whether we have to wait under 6 months of age, even if the patient is having ptosis, you can wait, because unless the patient acquires an erect posture, the upper lid is not covering the pupillary axis, so there is no risk of amblyopia and mild ptosis with Marcus-Gunn phenomenon, and always address squint before ptosis. And as Dr. Indu said, rule out myogenic ptosis. Then comes the question, which procedure? So it depends on the degree of ptosis and LPS function that Dr. Indu has elaborated in the previous talk. So depend on the levator function. If there is good levator function and the ptosis is mild, I'll go for Fastenella servet or Muller's resection. Moderate to severe ptosis, LPS surgery. Poor ptosis, frontalis suspension. And in between cases, we may require combination of procedures. So Fastenella servet, we are excising the upper border of tarsus, lower border of Muller's muscle and conjunctiva. So maximum amount is 3 to 4 millimeters, and it will depend upon the, 1 millimeter ptosis if you aim ptosis correction, then 2 millimeter of resection is the calculation. So what you do is you have to evert the upper lid over a clamp or traction sutures. So this is everted upper lid over traction sutures, and you calculate, previously you have to calculate the amount of resection, and an artery forceps is applied at the proposed site, and you have to pass sutures. Here 80 vicryl sutures are passed in a continuous fashion. Small bites are taken, and till you approach the lateral end, you have to do this. So once you reach the lateral end, leave it like that and remove the clamp, then you can excise, and care should be taken not to touch the previously sutured area. After that, with the other end of the 10-0 nylon suture, it is a double arm suture, you can close the wound in a locked manner. So these two sutures will give reinforcement for the wound. Similarly, proceed till the lateral end. And once you reach the lateral end, you can exteriorize both the sutures and tie at the skin aspect. And to prevent corneal abrasion, you have to use a bandage contact lens, and up to 3 weeks it has to be like that. This is a patient with good correction after Fastenella servet surgery, but you can have under correction, over correction, etc. The next one is LPS resection. So there is conjunctival approach and skin approach. Various algorithms are available, but what I do is I try to match it with the opposite lid if the other eye has no ptosis. Otherwise, around 3 to 4 millimeters above the pupil. So marking has to be done in the sitting position. It is ideal. Here we have marked the lid crease, and because the patient is having excess skin also, we are doing blepharoplasty. So that is a blepharoplasty incision. Local anesthetic is injected, and we are cutting along the previously marked areas. So either you can use a cautery or blade, and then you have to resect the excess skin. Bleeding points are cauterized. Then incise the orbicularis till you reach the upper border of the tarsus. If you do it more, there can be chances of lash ptosis. You have to expose only the upper anterior part of the tarsus. Then the dissection is carried out superiorly till you reach the orbital fat. So this orbital fat is a good landmark. It is pre-aponeurotic in position. So over anterior to that is the orbital septum, and posterior to that is the levator muscle. So you can see the orbital fat here after cutting the orbital septum. So you have to cut the orbital septum in the full length of the wound, and behind the fat is the shining edge. This is the rolled up levator aponeurosis. And next step is to isolate the levator aponeurosis from the underlying conjunctiva and molars. For that you have to inject various procedures are there. I inject saline or block local anesthetic at the subconjunctival pain, so it will balloon up the conjunctiva and you can easily separate the LPS. Then kit with a 60 silk suture from the tarsal plate, and blunt dissection is done till you reach the witness. Do it superiorly. And before that you have to calculate the amount of resection to be done. Then levator has to be reattached to the tarsal plate. So partial thickness bites are taken with the Proline suture, 5 Proline suture. Check whether it is full thickness, otherwise it will injure the cornea. And 3 such sutures are taken, and the central suture is the one which determines the lid height, and medial and lateral sutures to see the contour of the lid. So better to pass it obliquely at the tarsal side. And once you have done that, you can do a slip knotting and check the correction. And if you are satisfied with the correction, you can make it permanent sutures. Then excess of levator is cut. Then comes crease forming sutures. That the lower part of the wound is attached to the stump of the LPS, so that nice little crease is formed. 3 such sutures are put with white ring. Then close the wound with the continuous sutures. Again, the Proline sutures are used for this. Continuous subcutaneous sutures are placed till you reach the angulation of the blepharoplasty incision. For the remaining part, we are using interrupted sutures. And nowadays, we are not putting closed sutures. We are putting a lot of ointment for lubrication, and we will use eye shield. So these are some of the good corrections I obtained, but the complications can occur. This is peaking of the lid. There is some peaking in the medial part. Under correction, this boy had poor levator action, not poor, fair levator action. So it is bit under corrected. He may require a secondary procedure. Other problems are overcorrection, lid lag, etc. Next comes frontalis suspension. There are various methods. I do Fox pentagon method. So 5 incisions will be there. 2 above the lid margin in line with pupil, and 2 in line with medial and lateral canthus over the eyebrow, and a central main incision at the pupillary line. Materials used, we commonly use silicone sling. It is a silicone sling has 2 attachments to the both ends with malleable needle and a sleeve through which the sling pass. So this is a video of frontalis suspension. So we are marking the stabbing incisions. The median central incision see a bunching of skin above the lip crease. Then tighten the sleeve, looking for the symmetry and height, and passing through the sleeve. Where it goes down the initial before cutting the needle off, we are passing it once more through the frontalis pocket so that at the end it won't bunch up at the incision site. Then suture the wounds, the lid crease incision and the stab incision we have made earlier. And while closing the central apical incision, take care it is not passing through the sleeve and lift it and suture it. We are putting 3 horizontal mattress sutures. So while removing, we know that 3 sutures has to be taken out. And eye is padded with shield, I mean not with padded. Lot of ointments we put and shield is put over that. So this patient, I did that vertical without blepharoplasty, so some bunching is there. So in this patient, I did the procedure just I showed, so I think it has better outcome. Complication, most commonly we see lag of ophthalmos. We have to warn the patient before that and put a lot of ointment, and mostly it will settle over a period of time. And under correction, over correction, suture granuloma, are the other complications. This boy developed a suture granuloma, and I had to remove the sling. And inappropriate contour, patients are very much bothered about it. So before tightening, you have to make sure that contour is okay. And lastly, beware of bilateral ptosis. This due to Herring's phenomena, even when we operate one eye, the other eye can droop down. So this lady, I did left eye LPS resection, and she got good correction. So when you notice there is slight drooping of the right eye, but she is working abroad and she has not come yet complaining that. And this lady came with right eye ptosis, and I didn't do any ptosis correction after applying ice pack. You can see the eyeball, eyelid has lifted up. So all these conditions you keep in mind before deciding on ptosis correction. Thank you for your patient listening.
Thank you, Dr. Ann, for that wonderful collection of cases. Very nice videos. Now I would like to invite my own mentor, Dr. Ani Sridhar. Madam will be talking on complex ptosis and their management.
I thought it was complicated ptosis. So it's complex ptosis. Okay. Whatever I found difficult. So, PowerPoint. Slide. ഇതിൽ വന്നിട്ടില്ല. So we are 85 to 90% of the time we are happy, the patient is happy, we can get corrections as good as this. But there are instances when the patient and the doctor is not happy. So under correction, my eye looks the same, lateral eye is drooping. Lateral eye droop is always, even after you correct, that persists. I don't know why. Even if you correct that side more, medial droop persists, and all those things you have to hear in the OPD. So at that time I tell the photographer, you have to, when you take the post-op photo, you have to ask the patient which eye was corrected. So even though the patient is little not satisfied, the photographer will correct that into satisfaction. So, so the single most mistake that we all do is measuring the levator function. After the PGs do the ptosis workup, I only check the levator function, because you should not make the mistake of pushing down the eyebrow, and also the scale should not ride on your finger and go up. So all these, levator function is the single most important measurement which determines surgery. And as Indu very nicely pointed out in a talk, look down and see if it is aponeurotic or congenital. I think all of you know why it's a congenital. The palpable fissure widens because the levator is dystrophic and fails to relax. In aponeurotic, the lid is lengthened, so the aperture will be less. So you have to resect less for aponeurotic ptosis and more for congenital ptosis. So yeah, so you can get an overcorrection. In my first days, the next day I have gone and loosened the sutures. You can get an overcorrection in aponeurotic ptosis very easily, especially in your earlier days. Now coming to complications which are peculiar to sling, there can be a slippage from one side, but is slippage the sole culprit, or loosening of the sling the sole culprit? You can see that preoperatively you have to see if the frontalis of the patient is acting. If the frontalis is not acting, it means most probably the post-op, the sling will be undercorrected, because the patient is not lifting the eyebrow and you are hooking the sling onto the eyebrow. So you may have to resort to other methods, new methods like frontalis flap, etc., which I think Marian will elaborate. And hypertropia can also be masked after surgery, and you can hear the mother saying that it looks the same. And always, as Indu pointed out, always rule out myasthenia. I've had 4 or 5 cases in which after levator resection the lid starts to droop after 4 or 5 years. So if the ptosis is alternating, you do not do any other test for ocular myasthenia. If the ptosis is alternating, you can straight away diagnose myasthenia. and look for ask for diurnal variation to bring photos, do an eyes test or a neostigmine test to confirm the diagnosis. Eyes test in the OPD is very useful and it's very sensitive too. Then another complication which is peculiar to the sling is the suture granuloma. This we have seen, we took the internal audit and we had done 84 cases in 2 years of sling alone, and we found that most of them were cases of blepharophimosis. I don't know what is Marian's experience. Most of them, the suture granuloma were of blepharophimosis patients, and I think 1 or 2. And in such cases, you will have to take out the sling and then re-sling it. That is the only thing. It is not an infection. No need to treat with antibiotics or anything. Then in myasthenia and myopathy, you have to look at the Bell's phenomenon, which is tested on gentle closure of the lids. Bell's phenomenon is tested. You have to know when the patient is sleeping, are the cornea exposed. So gentle closure, don't forcefully close and look for Bell's phenomenon. Gentle closure of the lids, and orbicularis weakness should be tested by tight closure of the lids. And in myasthenia, you can look for orbicularis peak sign. If there are PGs here, orbicularis peak sign is when you tell the patient to squeeze eyes shut for 5 minutes. The eyeball will peek through the lids after some time because of the orbicularis weakness. So we found that one case of myasthenia we had done had orbicularis weakness, and she developed a corneal exposure. So I think more than Bell's phenomenon and Shermer test, orbicularis weakness is the one which is more prone to produce corneal exposure. So on the table itself, while surgery, we apply Visilon, and we avoid a frost suture, that is suturing the lower lid to the and taping it to the upper lid. We don't do it because the next day when we open the pad, the suture will be rubbing on the cornea. For many years now we are not doing it. And lubricant ointments, not gels. The gels are not, you have to see if it stays on your hand, put it on your hand and see if it stays on your hand. So if you put ointments at night on the cornea, it's it can prevent corneal exposure, not gels. And shield should be used at night to prevent exposure, and also glasses during the day. Now, Marcus gun phenomenon is another area where I think not getting very good results. It is said that Marcus gun phenomenon in children decreases with time. It doesn't do so. Actually, the patient adjusts, especially girls will try to learn to adjust their chin position and lift the lid. That is how it decreases with time. See how the child in the here the lower slide is how she is adjusting and lifting the lid. So, but if the ptosis is mild with lid retraction, need not do anything because even if you do sling, it will remain in the same position, and levator can increase the Marcus gun phenomenon. As in this case, you see that actually it's an inverse Marcus gun phenomenon. When she's opening her mouth, the other eye is also drooping. So, but she was happy because in the primary position, the ptosis was corrected. So, a small levator resection can be done, telling her that it will increase when she is chewing and all that. Now, another thing is aberrant regeneration of third nerve. Long after trauma, the patient can develop this, where there are lid movements with eye movements. The lid position height will change with eye movements. So in such cases, if you correct the squint, somewhat the ptosis can also be corrected. I don't have much experience. I think 1 or 2 cases only. Now, when you third nerve palsy, when you do a sling, you correct the ptosis first, bring the eyeball to the primary position, and then do a sling. But whatever you do, everything recurs, and they are more prone to dry eye. But you can tell the patient and do, that's all. You have to do a globe fixation. The squint surgeon does a globe fixation, but even then it recurs. You have to tell the patient it will recur, not to the same extent, but it will recur. And they are more prone to dry eye also. You should be very careful. Another case where ptosis, which is a little complicated, is a neurofibromatosis. See, you can see an S-shaped ptosis with lateral third of the lid will grow more than the other parts of the lid. So the thickness and the length of the lid will increase. and you have to look for caffeolar spots. You have to take a CT scan to see if there is any absence of wing before you give GA. So this I have just put a video. Don't know if we usually operate. We usually take videos sitting at the head end of the patient and under the operating microscope. So you have to shorten the lid vertically and horizontally. So I have marked a blepharoplasty incision. It's not very clear. Then look at, and now I am marking a pentagon where I am horizontally shortening I plan to horizontally shorten the lid by this much extent. So the pentagon is excised and you have to debulk the neurofibromatosis tissue. What is the classical description of neurofibromatosis tissue? Bag of worms. So you can see the bag of worms there, and we can use a separate Klein solution to reduce the bleeding, and otherwise it bleeds very much. It's very difficult to do. Klein solution is where you add an extra vial of adrenaline onto the lignocaine adrenaline bottle, then dilute it to 10%. So here after that I am suturing the lid by a full thickness suturing. Mattress suture is first put, and the sutures are then buried in subsequent sutures. Now the horizontal shortening is done, and the blepharoplasty incision is then closed. So you will have to debulk a lot for that bulkiness to go away. Now another condition is blepharophimosis, where there is a telecanthus and maybe sometimes epicanthus inversus, and ptosis and ectropion. So here when the child is having severe ptosis, when the child sits up, you can do a sling. At 8 to 9 or 10, 1 year of age, you can do a sling to clear the pupillary axis. And then do a medial canthoplasty should be done at least till the child, should be done only till when the child is 3 to 4 years of age. So you get better results if you delay the medial canthoplasty till later ages. And then after medial canthoplasty, you may have to repeat the sling. So again you may have to do a second sling. So first sling I mostly put ethibond, and then you can just take it out and do the silicone sling later. Another cases where we have to do a rehabilitation of microphthalmos and anophthalmos. Here even when the child is very small, when few months old, we put a conformer and slowly increase the size of the conformers till the palpebral aperture is increased, and then we do for some cases we do if the palpebral aperture is too small, we can do a medial canthoplasty and a sling to increase the horizontal and the vertical fissures. The horizontal fissure is increased by the medial and lateral canthoplasty, and the vertical fissure by a sling. So that is the medial palpebral ligament. I am disinserting it from it is lengthened actually. I am disinserting it from the insertion, shortening it, and now to get a little laxity, I am doing a lateral canthotomy. Don't do a lateral cantholysis, just do a canthotomy. And then I am coming back to the medial palpebral ligament. 5-0 double armed ethibond sutures are placed. Always knot it when you are doing that, because it can cut through. Knot the ligaments. Even in lateral tarsal sling, knot the tarsal plate and then only suture it to the periosteum, closing the skin. Now I am going back to the lateral canthus, suturing the conjunctiva to the skin, reforming the lateral canthus. I have just done a canthotomy, don't do a cantholysis. You can see there is inferior fornicial prolapse also. Now a sling is done to increase the vertical palpebral height. This was an earlier video, so we were using a vertical sleeve. Actually, Marian gave me the idea of using a horizontal sleeve, but I don't know if her method and my method are the same. Just she told me over the phone, I started doing it. So, and there can be a watering. You have to see, can probe the canaliculus, but watering is there because of the kinking of the canalicle. We can't do anything. I did a phonics formation suture also for this patient. So you can see on the table itself there is a obvious widening of the vertical and the horizontal palpable fissure. So at school going age, he could be given a custom artificial eye. Another case which we have difficulty in treating is a congenital fibrosis syndrome. Many of you would have seen there is defective elevation of both eyes, frontalis overaction and chin elevation. So when the child grows up, this chin elevation comes down. Otherwise, for looking at everything above that level, the patient has to lift the chin. So even if you do a ptosis correction, the chin elevation will not be eliminated. So that you have to tell the patient. But ptosis correction improves the condition. So that is another patient. Thank you.
Thank you, Dr. Annie, for that elaborate talk on complicated ptosis. Next, I invite Dr. Marian Poli, a senior consultant from Giridhar Eye Hospital, for her talk on what's new in ptosis surgery. Over to you.
Yeah, good morning. I thank Dr. Indu for this. So, my topic is what's new in ptosis surgery. To be frank, actually nothing new, but we are doing some modifications. And more than that, ptosis is Richard Dorsby, he's the father of ptosis surgery. He has put across in his book as ptosis is hell. So that still holds true because even though whatever advances has come in the technique, each case is very, very, very unique and you have to customize for each cases. So my something which we are doing little differently because one is minimal incision levator advancement. It's called MILA because in ophthalmology you know MICS, MIVS, MIGS. So this will add to it MILA. This is actually not new. In the year 1999, Lucarelli, he's a very senior oculoplastic surgeon from US. He has published in American Journal of Ophthalmology Small Incision External Levator Repair. And after many years, in 2023, there are a few modifications, that is septum sparing minimally invasive technique for levator advancement surgery in aponeurotic ptosis. So this is not new, but what I'm doing now, I'll just show a small video.
Lid crease marking done. Traction sutures taken. An 8mm lid, crease incision done with the help of radiofrequency cautery. Orbicularis dissection is done. Suborbicularis dissection carried out in preseptal and pretarsal plane. Minimal pretarsal orbicularis is excised. Orbital septum is opened and retracted. LPS aponeurosis identified and sutured to the tarsus with non-absorbable single box suture with 6-0 proline after adjusting the lid height.
So after, just take one suture through the tarsus to the levator aponeurosis and take the lid crease forming suture. So that's it. So this is a few patients. So first patient is actually, she had undergone cataract surgery and she was eating cataract surgeon's head that she can't read, she had lots of watering, irritation, etc., etc. So if you see carefully, you can see her, she has got ptosis both eyes. And in the right eye, you can see the punctum is opposed. The problem is when the punctum is opposed, all these problems, functional NLDO leading to watering, irritation, etc., and she is 84 years. So like, no, I don't want to do any big surgery. So I just corrected with the Milla, both eyes. It's just like both eyes together will take only 15 minutes. So it's like more or less as fast as IOL surgery. It's like that in the left eye also. In second patient, left eye I have operated. She had mild undercorrection which became all right later. So this is a very quick procedure. Here the advantage is very, very quick and fast recovery and similar success, more or less similar success as standard levator. But the disadvantage is sometimes if the suture is not really in the correct plane, you can get contour abnormalities. Similarly, overcorrection, which we have already saw. And if you're planning any adjunctive procedures like blepharoplasty, it will be difficult with Mella. So this is just to make the patient comfortable and will finish very fast. So now coming to the frontalis muscle flap. So again, frontalis muscle flap is also not very new. In this article by Song et al., he has already published in 1982. That is almost like, more than 20 years back. And in 2016, it's again in the Plastic Surgery Journal that published a 10-year follow-up. So in that they have reported almost 20% undercorrections, etc. So now people they wanted to see how it works in our ophthalmologist hands. So I'll just show a small video. Here the initial steps are the same. I'll just show only the important part. So suborbicularis. So suborbicularis dissection is done. Here we have to reach up to the orbital rim. And then you have to lift the frontalis muscle flap. So now the flap has already been raised. So this is the now I'm holding is the raised flap. Yeah. And I take a bite through the tarsus, levator and frontalis muscle flap to get so that it follow that contour and you should not get any peaking or any off the globe phenomenon, that is lid off the globe phenomenon. So this is the correction which you can get. So this is, you are taking a frontalis muscle. Basically, you are combining frontalis muscle as well as the orbicularis oculi muscle. So now look at the results. So initially, I was very enthusiastic in doing flap alone. So this is the one patient that again blepharophimosis. So I have operated both eyes. In the right eye, I have combined sling with muscle transfer. That is muscle flap, orbicularis, frontalis muscle flap, and the left eye sling alone. So if you look carefully, in the right eye, there is a good correction with a good crease, and the left eye little undercorrected. So this is one thing. Now what I have started using is combining frontalis sling with silicone and frontalis muscle flap. So this is another case. It was one of my first case, where I did only muscle flap. Even though initially he looked little okay, but 8 months, 1 year down the line, he had undercorrection. And now I am he's waiting for, actually I'm planning to revise with the regular frontalis sling. So it is, so this is another case. This patient I have operated 10 years before at the age of 4 years. Now she is 15 years and she just came for anything can be done. So here the sling has migrated little bit in the up. So for that I have done frontalis muscle flap, so that with flap alone the crease has improved and he got a good correction. So this is for the frontalis muscle flap. This is a very good procedure, but flap alone, I'm not very keen on doing it now. I'm combining both facial silicones with frontalis muscle flap, which gives very good result in almost all the cases. So now the third thing, no, this is also something new which we are doing now. So there is an article published in 2019 OPRS, that is orbital septum fibrosis in congenital ptosis correlates with eyelid function, a clinical pathologic study. So here what they have studied is the laxity of the lid is reduced because of the fibrosis of the orbital septum. So in all the congenital ptosis surgeries, you know the pathology. I am excising. Usually we open the septum and do the levator resection. So what I'm doing is I'm excising a part of the orbital septum and then doing the surgery. The advantage is we'll get good correction, as well as the lag of thalamus is very, very less, practically zero, especially with the levator resections. So these are the three things which I want to highlight. One is Mila, and second is frontalis muscle flap, and third thing is excising the orbital septum. Thank you so much, and this is 2026 OPI. Thank you.
Thank you, Marian ma'am, for that great discussion, really enlightening us on the newer techniques.
Any questions from the audience for the speakers?
When you take a flap, do you separate the levator from the thing and then do the lid crease formation? You separate it from the
I separate the levator from the tarsus, then make the flap. So take sutures from tarsus, levator, muscle flap, then it's a box suture.
thing is done after the flap, same sitting. Not lid crease formation is not that great in flap, and that dynamicity of the lid is not there.
My question to the speakers, Mariam ma'am and Ali ma'am, how much do you rely on acetylcholine receptor antibody assay in myasthenia, or do you rely on neostigmin? How does it affect?
That is just to predict if the patient gets a systemic myasthenia or not. And sometimes when we refer the patient to the neurologist with one eye slight ptosis and all, diurnal variation, everything is there, systemic is negative, should we treat with neostigmin tablet for such a small ptosis? Or but even if you do levator resection, you can tell the patient it can droop, it can recur, and then do the surgery instead of treating his whole life for a ptosis, small ptosis with neostigmin.
Continue on that medication. Most of the time they go into fibrotic stage. At that time, if we intervene, we get good result. Initially it is ups and down. Yes, when that it is in the fibrotic stage, when the ptosis is stable, then we can go for surgical correction. That's what we do.
One eye should be treated with neostigmin tablet.
Anti-musk antibody and single fiber EMG will help when you are in doubt, rather than putting the patient on long-term pyridostigmine. It's like most of the time.
And one more question, you told about combining flap with sling, right? Can you elaborate more on that?
The thing is, initially, if you 1 or 2 cases I did flap alone, all went under correction. Initially, first week, 1 month, fine, but 6 months down the line, getting under corrected. So what I thought is the muscle is becoming loose. That's what I feel. Patient obviously will not. Advantage is sling will actually lift and flap will give the crease. So that is the advantage what I felt. So that's what I feel. Sling will actually give the lift. Flap will give an additional lift and give the crease also. So all. Yeah, I think facial latte is the best.
So
but again, a scar on the leg. That is again cosmetics. Yeah. Now I have done facial latte also. It's doing extremely well. But it is, you have to take facial latte, general anesthesia, a lot of things. Yeah.
So just to summarize, if you were to counsel a patient for ptosis, ma'am, what all would you tell the patient, what to expect and all that?
In children, I call the mother and I'll show how will be in the, mostly I'll be doing sling in, to prevent amblyopia and all. I'll show them how to put the ointment, how will be the lid in the down gaze, that you have to tell. And also about prolonged ointment medications, that also you have to sell. And also can happen under correction, over correction, so one more sitting may be necessary. Anticipatory veil always to take. And one headache is this myasthenia, we don't know, patient will tell about evening droop and all, we are not sure what to, we will always take an anticipatory veil.
Yes, I think with this we'll wind up the session. I think we had a great feast on ptosis. Thank you, Dr. Anne, Annie ma'am, and Marian ma'am for this great talk. Thank you.